ايجيبشن انتنسيفستس ايه اللي ممكن يقدموه لحضراتكم في النيو بايب لاينز في الاي سي يو على مستوى العالم. ايه الجديد؟ سبقني الحقيقه الاستاذ الدكتور سامح سالم والاستاذ الدكتور ياسر عبد الرحمن في فيري تو نايس توبكس. الحقيقه انا هكمل وراهم الابديتس في الاي ار دي اس. الحقيقه هو توبك صعب كالعاده، والحقيقه انا طول عمري مقتنع ان الكالكوليشن از ان ارت، وان اللي يقدر ان هو يشتغل في الاي سي يو ان جود شيب لازم يكون از جود انتنسيتي. هم الدقيقتين دول عارفين. بسم الله الرحمن الرحيم. سريع عشان السيشنز اصلا قصيره. في 2024 بدات في يناير in January 2024 بدانا بنيو جلوبال ديفينيشن فور ARDS، وده كان موديفيكيشن للاست ديفينيشن في ARDS اللي كان سنه 2012 وهو ما يسمى المين ديفينيشن about definition and categorization of ARDS. النيو جلوبال ديفينيشن في ARDS سريعا كان فيه ريزلتس واضحه جدا. الريزلت دي كانت بتتكلم على 4 حاجات. ان ايه الجديد في ARDS؟ اول حاجه ان احنا لازم ننكلود النون انفيزيف او نون انتوبيتد ARDS، يعني كل البيشنتس اللي موجودين على هاي فلو نيزل اوبشن اكتر من 30 لترز والساتوريشن بتاعهم below 97% can be categorized in the ARDS group which was not before. تاني حاجه ان احنا بقينا بنستخدم بدل البي اف ريشيو كهايبوكسيا، يعني عشان ساين فور هايبوكسيميا اتغير الديفينيشن ان يبقى في الانتوبيتد بيشنتس وفي الهاي ريسورس كونتريز كان بناخد بلاك جازز تشوف البي او 2 على اف اي 2 فيبقى في حاجه اسمها هايبوكسيميك اندكس اللي هو البي اف ريشيو. دلوقتي الشيفت الجديد ان احنا نستخدم البي او 2 لو المكان ما فيهوش بلاك جازز او ليميتد ريسورسز بالاس بي او 2 على اف اي 2 ريشيو، وبدا يبقى دي ابلكيشن. ثالث حاجه طبعا الايمجنج بروسيس. الايمجنج بروسيس هنلاقي في الاكزامبلز اللي هقولها دلوقتي ان تحول من مجرد التشست اكس راي والسي تي او ذا ستاندرد فور ايمجنج اوف اي ار دي اس addition to them the ultrasound of having bilateral infiltrates of B lines in the lung ultrasound. والfourth thing اللي كانت very surprisingly وكانت منتظره ان في الريسورس ليميتد سيتنجز احنا مش محتاجين نشوف ولا الاف اي 2 ولا البوزيتيف بريشر، لان ما عادش فيه او it's not standard anymore to have a positive pressure in the equation of the ARDS. To make things shorter and easier هتلاقوا هنا حضراتكم الكرايتيريا اللي اختلفت في النيو جلوبال ديفينيشن. في النون انتوبيتد اي ار دي اس دلوقتي بقى في ترمينولوجي اسمها نون انتوبيتد اي ار دي اس بتعتمد على بي اف ريشيو اقل من 300 او اس بي اف اي 2 ريشيو اقل من 315. ده في حاله استخدام الهاي فلو نيزل اوبشن على فلو اكثر من 30 لتر بير مينت في وجود ساتوريشن اقل من 97%، لان الساتوريشن الاس بي 2 لو فوق 97% I don't define this patient standard wise as hypoxemic، هو اصلا مش hypoxemic. فده الهايبوكسيميا الهايبوكسيميا ديفينيشن في النون انتوبيتد اي ار دي اس. انما في الانتوبيتد اي ار دي اس ذا سيم بي اف ريشيو اقل من 300 مايك اقل من 200 مايك اقل من 100 سيفير، وبدا يخش الريبليسمنت بتاع الاس بي او 2 والترنيتنج للبي او 2 في النون فنتليتد كيسز، بحيث ان هو نقدر نحسب الاس بي او 2 ريشيو وبيبدا من 315 315 in the mild form from 235 to 315 moderate 148 to 235 and in severe form من اقل من 148. المسج هنا فين؟ المسج that we are changing the practice from having a fixed measurements related للinvasive intubated patients with hypoxemia to another two groups, non-intubated high flow nasal option and having a new modification in the definition of hypoxemia in resource limited setting. An example البسيط للموضوع: these are 3 types of patients. The first one is a 68 years old male, abdominal sepsis, septic shock. This is his chest X-ray, and this is his oxygenation when he is intubated. This is intubated case. He is ventilated with FO2 of 0.5, PO2 is 75, PF ratio is 150. This intubated ARDS, moderately severe form. This is the classical ARDS Berlin definition. While this lady is on high flow nasal, and this other lady on oxygen mask, having a pattern of hypoxemic insult, bilateral lung infiltrates in the first case, with high flow nasal oxygen of flow of 40 liters, and the SpO2 FiO2 ratio, the new terminology, giving us a SF ratio of 114, which meaning to a non-intubated ARDS. The last one, putting a simple face mask with the 15 liters of oxygen, and having a lung ultrasound, bilateral B lines. This is the radiology, this is the mask, and again the SpO2 is 85% on FiO2.6 of the high flow oxygen Venturi mask. So this is an ARDS in the resource limited setting, non-intubated ARDS. To make things more complicated a little bit, this was a British a medical journal publication in the same year, this year, about what's new in this definition, how will be applied, what we will gain from it. This is the old theater, starting from 1998, passing by 202, the American European Association consensus guidelines about the first definition of ARDS, and lastly by the new global definition, and these are the major changes in the definition between the last definition and the first definition in 1998. Actually, it makes sense in the four categories I have mentioned. The hypoxemia, using high flow nasal as a prototype, using the saturation as a prototype, and adding the lung ultrasound as a new technique. I think this will be summarized most probably in this issue about the severity of the ARDS definition. This is the new issue, to use the severity of ARDS classified as mild, moderate, severe, or ARDS under high flow nasal, or ARDS in non-intubated cases using the saturation issue. To make things more and more sub-classified, the ARDS was sub-classified in this article in the British Medical Journal, starting by the phenotype of ARDS, summating the observable set of traits, resulting in the interaction of genotypes and environmental exposure. This is an ARDS. Things are getting changed. We are saying that we have groups of sub-phenotypes of the ARDS. You might have a ARDS classified according to the sub-phenotypes, according to the cause. It is pulmonary origin or extrapulmonary. Pulmonary means that you have a pneumonia-induced ARDS, and extrapulmonary means that you might have a pancreatitis-induced ARDS, a trauma-induced ARDS. What's the difference between them? There is a lot of difference in the management plan between the pulmonary and the extrapulmonary. According to physiology, you can classify according to the severity, according to Berlin definition, mild, moderate, and severe, and each of them will have specialized treatment strategy. By radiological assessment, is it focal or diffuse, focal or non-focal? And lastly, the biological classification of the subphenotypes. Is it having an epithelial injury, endothelial dysfunction, or not? Or it is hyperinflammatory or hyperinflammatory. To make things more clear about this point, I think we need to make sure that everybody understands that you might have two patients having ARDS. One of them is having a hyperinflammatory and you go for steroids. The other one is having hyperinflammatory, you never give steroids. You have a patient with a focal ARDS, you go by recruitment maneuver. It's a very simple approach. And if it's non-focal ARDS, most probably you will be very reluctant to put him on recruitment or high peak strategy. So things are changing in the world. It's not anymore ARDS binary. How about the management updates? This was the definition updates. What about the management updates? The European Society of Intensive Care Medicine has published in the middle of 2023 the updates in the guidelines of the management of ARDS, with a recent update by the American Thoracic Society in 2024. What are the new in the guidelines? I think very few. They had around 8 questions about how to manage ARDS. The first one was handling the high flow nasal option. What about the recommendation of using high flow nasal option to decrease the risk of intubation in acute hypoxemic respiratory failure or early ARDS versus, in the first question, versus conventional oxygen therapy like the mask. And the second question was using high flow nasal oxygen against the non-invasive ventilation. Actually, both of them gives a very weak recommendation of using high flow nasal against conventional and against the non-invasive. The positive sign here is using the high flow. It's recommended to use the high flow nasal oxygen against the conventional oxygen mask in decreasing risk of intubation. Why? Because if you use high flow nasal, you'll have a big chance to give a high flow, high FR2, and this will make the patient more comfortable in the early stage of ARDS. So, making sense against flow of 12 liters in the conventional oxygen mask, this is a very clear recommendation. Apart from this, it didn't decrease the mortality, it didn't decrease the risk of intubation against the non-invasive CPAP. Second question was using low tidal volume ventilation. Actually, this is the only strong recommendation from 2000 in the ARDS network trial. Till now, it's a very strong, high level of recommendation to use low tidal volume ventilation of 4 to 8 ml per kg per rated body weight. What about the PEEP and the recruitment maneuver? I think this is the issue. I spent the next 7 minutes discussing the theory of using PEEP, recruitment, PEEP and recruitment. If you are saying or asking about do you use high PEEP or low PEEP in ARDS, what do you think? Till date, and these guidelines published, there is unable to make a recommendation for or against using a high PEEP or low PEEP. Very strange recommendation. There is no recommendation with or against high or low PEEP. And the other issue, there is no also recommendation of using the PEEP titration by lung mechanics, usage of lung mechanics, against the fixed table of PEEP FR2 published in the ARDS network in the early 2000s. So there is no strong recommendation advising using high PEEP versus low PEEP, titrating PEEP by the regular lung mechanics versus titrating PEEP according to fixed table. So I go directly to my last point of the presentation. What do you think about the non-recruitment maneuvers? Actually, in 2024, I tried my best to catch the latest updates about recruitment maneuvers. I am pro recruitment. I suppose that he reached the last 10 to 15 years using recruitment maneuvers, and so it was one of the main topics I needed to revise. This publication was published in the intensive care medicine this year about using what's called recruitment to inflation ratio. Anybody is using this recruitment to inflation ratio? Anybody previously known about it? This is a new modality of assessing how can you recruit the patient, and is your patient having any chance to be recruited or not, and if there is a chance, how to apply it. I had three studies about this in the last year. The 3 of them are published in intensive care medicine and maybe respiratory care and a local journal. This is the ideal study. I'll check with you the concept of recruitment to inflation ratio. Actually, it depends on using the one breath de-recruitment maneuver. It's one breath technique, and it's assessed by CT technology for assessing or validating its success. What we do in this protocol, you start your patient by low PEEP phase, you put your patient on a PEEP of 5, and stay for 1 hour. Then you increase your PEEP to the high PEEP level by increasing the PEEP to reach a plateau, safe plateau of 28 to 30. So you have low PEEP phase, high PEEP phase for another hour, and this is according to the EXPRESS study or the EXPRESS protocol study. Then you start doing a one breath recruitment maneuver. What does this mean? If you are putting a peep of 5 for 1 hour and a peep of 20 for another hour, and you decrease the peep from 20 to 5, what you will find? Most probably you'll find a change in the volume of the lung at this phase. If you are recruiting the lung with 5 centimeters of water, then you put it into 20 or 25 centimeters of water for 1 hour, and suddenly in one breath you decrease the peep from 20 to 5. This can simply be applied in this way. You never measure the total volume, you measure the end expiratory lung volume, or from decreasing the peep, from high peep to low peep, you find a big change in the volume. To make things easier, you need to set your respiratory rate in a very slow rate, at rate of 6, IA ratio of 1 to 2, and you'll have at this moment expiratory time of 6.6 seconds. Why? Why I need a very long expiratory time? To take all the volume in the lung out, so you can measure what's called end expiratory lung volume. This end expiratory lung volume, if it's too large, this means that you recruited a large volume of the lung. If it's too small, so you didn't recruit a good volume of the lung. This is the main issue. A lot of calculations. This is the CT, the first one at low peak. This is a lot of collapse in the focal ARDS, and after high peak, most probably is vanishing. And this is the area of the curve in the density of the lung in the collapsed area. It's very high amount of the lung in this phase. After putting a PEEP, it moved to the left in the area of well-aerated lung. A lot of measurements. Time is not with us, but the other issue in this study, they were measuring the lung strain. They were assessing how much this will affect the lung, how much ventilator-induced lung injury will occur, how much of the lung is damaged by putting high PEEP, low PEEP, and using a single maneuver, single breath maneuver to check is the lung recruitable or not. And they found that the dynamic strain is getting down when you are using this recruitment maneuver, while the static strain should be a little bit coming up, but finally the global lung strain is getting down. So it might help. This is a lot of physical equations, how they measured the RI. It's at the end a ratio between the recruitable part of the lung compliance over the baseline compliance of the lung at low peak. So you put a compliance after putting this single breath recruitment or recruitment study, and put the compliance against the baseline compliance. The ratio between the compliance after recruitment to the compliance baseline is the recruitment inflation ratio. Another study using the same 3 steps, potential lung recruitment assessed by the single breath maneuver, then a lung recruitment maneuver is done, and lastly, if the lung recruitment maneuver is performed by the pressure mode using fixed guided pressure and a PEEP of 25 to 30, then you use the decremental PEEP strategy to go to the optimum PEEP. So you have 3 steps. A trial of sensing the recruitability by the first single breath procedure coming from high PEEP to low PEEP. Then you put, if the patient is recruitable, you put him in recruitment maneuver, an easy maneuver of using a fixed driving pressure of 15 and a PEEP of 20, and then you decrease the PEEP slowly to get the optimum PEEP. I think we are about to finish this study. This was the recruitment maneuver after the initial single breath, and this is the optimum PEEP strategy. I'll start my conclusion in a few minutes, with this minute actually. This is another study, but we don't have a lot of time. Gattinoni, this is the final of this debate. Gattinoni had an editorial 1 month ago in the Times of Medicine assessing all this issue. And he concluded that you might have 3 or 4 categories of lung de-aeration, aeration, poor aeration, and consolidation at access in the de-aerated area. and you put the recruitment maneuver. You can measure by CT method. You find a recruitment of 14%. If you use the gas volume method, which is the PF ratio improvement, I agree, you might find the same patient with the recruitment 48%. They concluded that recruitability and using a personalized PEEP strategy is not a simple maneuver. Maintenance of recruitment is independent of the number of the lung units recruited, but depend on the physical characteristics, with the physical ability of the lung itself to be recruited or not. It's not the matter how much pressure you're putting in the lung. It's a matter of how the lungs behave to your management plan. So recruitability is important. It gives an important information about the severity of the disease and the amount of the atherosclerotic lung, while the PEEP selection doesn't meet the same page. The PEEP selection needs more integrated assessment of the lung elastance, transpulmonary pressures, hemodynamics to be at the end truly personalized. Thank you.